Hello, everyone. Thank you for joining us tonight. Today, we have a very special guest who I am honored to moderate the talk today. So, this series is titled Ask the Expert, and it is something brought about from the Kimmel Cancer Center Community Outreach and Engagement Team. So, this month is all about breast cancer awareness. So we're very excited to talk about breast cancer today. And it was very interesting. We had a lay health educator program through another initiative called Medicine for the Greater Good. And we talked all about breast cancer last night as well. So we had lots of questions. So people are very interested in learning more about breast cancer prevention, screenings, guidelines. So this is a hot topic. It continues to be a hot topic. So our series tonight is entitled What You Need to Know About Breast Cancer. And my name is Kimberly Haley Fair. I work here at Johns Hopkins Bayview Medical Center. I am also a part of Medicine for the Greater Good, where we speak about different health topics. So I am honored to fill in for our community outreach and engagement team tonight. So our conversation tonight will be with Dr. Razavi, who's here with us, and we'll be discussing breast cancer. So we know breast cancer is the second leading cause of cancer death for women in the United States. These data are from the CDC, and it's estimated that there will be 313,510 new cases of breast cancer diagnosed in 2024. And that is from the American Cancer Society. So tonight, Dr. Razavi, we're very excited to have you here. You can see Dr. Razavi on your screen. So I'm going to quickly read your bio. And if I'm missing anything, if there's anything, a fun fact, please fill it in. We love to get to know
Right.
our speakers. It helps to build community.
Sounds
So
good.
Dr. Razavi is the director for breast imaging in the National Capital Region. She oversees breast imaging operations at the Sullivan Breast Center at Sibley Memorial Hospital and Hopkins Medical Imaging in Bethesda. She earned her medical degree from Georgetown University School of Medicine and completed a residency in radiology at Georgetown University Hospital, followed by a fellowship in breast imaging at Memorial Sloan Kettering Cancer Center. That is a mouthful. And prior to joining the Sullivan Breast Center in 2008, Dr. Razavi was an attending physician and breast imager at Georgetown University Hospital. So welcome, Dr. Razavi. We
Thank
are
you.
very grateful to have you here. So I want to start by asking you, is there anything from your bio, anything that stands out to you, one of your most passionate projects, something that we could get to know you?
Yeah, absolutely. First of all, let me tell you what my bio doesn't reflect is that I'm a local girl. I was born and raised in Maryland, right outside the DC suburbs. So I'm all about everything about the DMV. That's one thing. And second, I'm very passionate about screening for breast cancer, including mammograms, and for those patients who need MRI. I think these are valuable tools we have, and I'm very excited to present them today. One of the things that was probably not in my bio, but I am very excited about, I'm very passionate about, is that I was on the medical advisory board for many years for Project Wish, which is the Department of Health initiative from the DC government, allowing women who do not have health insurance to get screening mammography. It is dear to my heart, and we've always been trying to work with them to try to find new ways and new facilities that can help accommodate patients who may need access. And we can talk about what Sibley in particular is doing with that later on, because that is something that's very near and dear to my heart.
I love that. Thank you for sharing your passions. We find that people, their passions fuel the type of work and research that they're doing. So we're always in the know of how did you get here? What made you interested in breast imaging? So we love personal stories, personal. So I will get us started with our questions. And for anyone that is just joining, welcome, welcome. We have a Q&A function at the bottom of your screen. So as Dr. Razavi is speaking, if you have any questions, please utilize that, type in questions, and we'll make sure to answer them at the end. So we do have a few questions for you, Dr. Razavi.
Sure.
So what are your current recommendations for breast cancer screening? So we have lots of different guidelines, lots of updates, different physicians recommend different things. So who needs to get screened and how often?
Well, Kimberly, I'm glad you asked that because you're right. There are so many different guidelines from different societies. Breast imagers in particular, and definitely the ones at Hopkins, we follow the guidelines that are established by the American College of Radiology and the Society of Breast Imaging, which for a patient at an average lifetime risk of breast cancer, the average lifetime risk is 1 in 8 women will get breast cancer. So the average lifetime risk, we recommend that we start screening for breast cancer at the age of 40, and we do it annually, meaning every year until the patient is in good health.
It's important. So why do we think that there has been, and I'm going off script a little bit,
Yeah, no problem.
why do we think that there's been so much back and forth with
And
updating guidelines?
yeah, well, there's some good reason, right? Because screening mammography does have false positive. We call back about 10% of patients. Those 10% don't have cancer. I mean, we call them back because sometimes it's just we need to do an extra view because the tissue might be overlapping on itself. And that does cause anxiety for patients. Some of the concerns from the different societies are, we're concerned about the anxiety that screening mammography might cause or impose on a patient. That's one. The second one is cost. Screening mammograms do have cost associated with them. And some of the society guidelines that did come out from the task force did incorporate cost as one of their indications for coming up with the new guidelines. But there's no question about it. We know that 1 in 6 breast cancers occur in patients between the age of 40 to 49, which is why we say let's start at 40. We know that 75% of patients with a new cancer diagnosis do not have a family history of breast cancer, which is why we say every woman after 40. And we know that if we delay mammography, if we change the guidelines from annual to every other year, which is what some of the task force do want to do, what happens when that happens is that we know that about 30% of cancers are delayed. There's about 30% delay in diagnosis in breast cancers. So because we recognize those numbers, we want to offer screening at a point where we have early detection. We know early detection improves treatment, which improves morbidity and decreases mortality.
That's really important. Thanks for sharing that. So as we're speaking about a woman being screened over time, why is it important for us to keep a record of our mammogram history?
Well, a mammogram is one of the benefits of mammography is comparing it to your old mammogram. So we look at the images and we compare to see if there's been any change. Obviously, we cannot assess for change if we don't have the old mammogram to see and correlate it with the new one. So it's really important for patients, and we always try to emphasize to patients, we love to take care of patients. We love new patients to come into our breast centers, but we really do emphasize that if you come, please bring your old films because sometimes a little cancer may be just signified by the tiniest little bit of change on the mammogram, which we won't be able to recognize without the old mammogram. So comparing to old mammograms is key.
That's wonderful. So how are patients keeping their mammogram history? So we have so much updated technology. Is it
Yeah,
still in my
you know,
chart? Where are they?
we want your mammogram on a disc. Actually, yeah. So we tell patients that you can't email those files; they're big, and we need really good resolution. Mammograms are read on really high pixel monitors, and so what we need is we need to have them be the highest resolution possible. So we really would like our patients when they come to any of our facilities at any of the Johns Hopkins sites to bring 2 years worth of prior studies. We love that because that allows us to provide the best comparison and make sure that we're recognizing even the most subtle change.
Great. That's wonderful. So how would I even know if I'm considered high risk for breast cancer? So I hear you talking about it, but
Yeah.
how would I even know when to go in to get screened?
And this is so important. We tell patients they need to have this discussion with the referring clinician. And could you show that slide for us? Could you share the slide for us now, if you can? The American Cancer Society has a whole, so we'll go to the next slide, please. Yeah, this is great. Thank you. That has a whole list of patients that qualify as high risk. These are patients who are not the 1 in 8. These are actually patients for whether it's because of known genetic mutation or because of family history or other concurrent syndromes. They may have a higher uh, incidence of breast cancer in their lifetime. So for these patients, we know that we definitely want to do the mammogram, but we want to do more. So for these patients, we generally will add an additional screening test, which most oftentimes is a breast MRI. That way we can do, that while they're looking for different things, the mammogram and the MRI, we know that we are looking at the breast tissue in two ways. One, in an X-ray format, like the like the mammogram, which is an X-ray, and two, with the MRI, where we give contrast to the patient, and then we let the breast tissue pick up the contrast, and then we look to see if there's anything that's picking up contrast differently than the normal breast tissue. And that can signify something developing. And so particularly invasive breast cancers, the MRI is very good at picking those up. So that's why we really do like knowing what the patient's screen, what their assessment is in terms of their high risk screening. And that conversation should be done with your doctor. We do have geneticists on site that can help tease through the details of your genetic history and your family history, but generally the conversation should begin with your primary care physician.
That's wonderful. So we see these supplemental screenings. So are there any additional tools that we may need once we find out we're high risk? So we may go to the geneticist. Are there any other screening tools after that?
Well, for breast, this is the most highly accepted use of additional screening is the supplement the mammogram with MRI.
Thank you so much.
Sure.
Let's see. Okay, so we can see you again.
Yeah.
Okay, our next question. Why do Black women seem to die from breast cancer more?
Well, sadly, that is actually an accurate statement. Um, Black women are about 40% more likely to die of breast cancer than a white woman. And so there have been a number of reasons that the studies have looked at to see why that is. One of the things we know is that Black women are more often get triple negative breast cancer, more commonly get triple negative breast cancer than a white woman. And triple negative breast cancer, when we say triple negative, we're talking about the hormone receptors, but generally speaking, triple negative breast cancers are more aggressive. So one of the thought processes was, well, this is a more aggressive tumor. It's more commonly seen in Black women than white women. So maybe it's partly due to that. However, some of the additional studies that are being done on this matter, because this is obviously of public interest to so many people, is that it's not just about the subtype of breast cancer. It actually seems like there is a correlation that with all subtypes, there is a higher incidence, higher rate of mortality in the Black female population than the white. So it brings us to wonder, what is it? So we do think that it might be a socioeconomic inequality, and it may be partly due to access to care and delayed diagnosis. So it seems like it's multifactorial, partly the tumor type, partly because the Black woman may not, the Black patient may have not had as early diagnosis or as, as good access to treatment or care. Um, so it is very disheartening when we see that, because that's when I brought up Sibley is trying to do something about that, because if I may I?
Yes,
Because
please. That was going to be my
this is such an
follow-up.
important, it's such an important topic. So I feel like I'm taking away everything from you right now. I'm going
No, that's going to be my follow-up. What are we going to do about that?
Oh, well, this is the thing. We need to improve access, right? This is so important. We have to improve access. We have the greatest, we have such great technology. We have breast mammograms, we have 3D tomosynthesis, we have breast MRIs, we have everything that we need to be able to offer early diagnosis to our average lifetime risk patients as well as our high risk patients. But we need to be able to get the patients to us. So one of the things that we've done, as I said, Project Wish is always an option for patients who are in the DC area. But the other thing that we have done is we have established a connection and a relationship with a clinic in Ward 7 and 8 in the District of Columbia, where it's an underserved population. And so the clinic there is in direct touch with our coordinators at Sibley. If they have a patient who comes in with a problem, or a referring clinician there, the nurse practitioner or the doctor assesses there is a problem with the breast, they are sent to us. And we do help with providing with transportation, but we do have coordinators who are in constant communication with the Unity Clinic. And so we arrange for access as well as the imaging, as well as the post-care, if the imaging leads to a biopsy, and if the biopsy leads to need for surgery.
That's wonderful. If I may ask about
Please.
Project Wish, are we seeing any barriers continue to exist outside of providing transportation? Are we surveying, asking people, okay, what other needs do you have that we could
I
help?
think I think one of the other issues that we're seeing, and I'm so glad we're doing this. Thank you for doing this tonight, because I think the other issue is that some patients are just afraid to come in for a mammogram. Um, some patients think it hurts too much, and I'm going to be the first to admit it's not a comfortable exam, but it's about 6 minutes total. So I think it's small time to pay to take care of yourself. And some patients are just afraid of what it's going to show. And so what we need to do is break that barrier, that stigma that goes with mammography. Breast cancer is very treatable when it's found early. And that's what we need to really emphasize to our friends, to our colleagues, to mothers and sisters and cousins. I mean, I think that's what's really important. And I'm so thankful to you and your team for doing this today. And I just hope that our viewers and our audience, take that message home, that it is a very small thing to do for yourself, but it really does save lives. Screening mammograms started being widespread in this country in the 90s. And the data has shown that since the 90s, death rates from breast cancer have gone down by 30%. So it works.
Yes, that is very hopeful. And I don't want to stay on this point too long, but my research interest is health literacy. So I'm always wondering how medical misinformation, community literacy affects our actions, right? Like what steps we take to take care of ourselves. Is it a lack of access or a lack of understanding? Because there's so much information out there.
Sure.
So
Sure.
who knows what information we pull. So I appreciate you bringing that up.
Well, you too. If there's something that you identify as we could be doing better.
I will put that and pose that to our attendees. So hello, everyone.
Yeah.
Welcome. If you have any suggestions, any comments, please put them in the chat. If it's a question, you can use Q&A. Either way, we'll find it. So we would love to open that to you all. We appreciate your openness, Dr. Razavi.
Yeah,
Um,
absolutely.
so let's say that a woman does have an abnormal screening result. So
Mhm.
you're coming there, you have butterflies in your stomach, and then you do have an abnormal result. What do we have? What do we do? What happens when that happens? And what's unique about your breast imaging team? We would love to learn about that as far as next steps.
Sure. So, as I said, we do call back about 10% of mammograms from a screening mammogram, and that does not mean it's cancer. Most of the time, it's not cancer. Most of the time, we just need to take one picture or maybe two pictures to show that it was a benign finding, maybe an overlap of breast tissue, and that resolves the question, and then we're done. But of course, there are times where it is a cancer. So if it is something abnormal and requires more steps, the radiologist will meet with the patient at that time. The radiologist will review what we have found and what the next step is. Usually, the next step would be an image guided needle biopsy, where depending on how we saw the lesion best, if it was on mammogram or on ultrasound, we do either an ultrasound guided needle biopsy or image or mammography, 3D tomosynthesis guided needle biopsy. Those are minimally invasive. We numb up the breast with lidocaine. They're in and out procedures. They take about 20 minutes. We tell patients to plan to be there for an hour and a half just because of the paperwork and everything that goes with it. You can drive yourself. You don't need to have someone bring you. You just need Tylenol for your care afterwards. Once we do the biopsy, when the pathology comes back, we do call our patient and review the biopsy results. Hopefully it's benign. 80% of the biopsies we do are benign, and that's what is expected in breast imaging. And if it's not benign and you do need surgery, then we have a team in place for that. We have coordinators that work directly with the surgeon's office. Our surgeons at all the Johns Hopkins sites are dedicated breast surgeons. These are surgeons who this is all they do every day. They are not going to take out a gallbladder 1 minute and then do your breast surgery the next. I mean, these are surgeons who are dedicated to the field of breast cancer. And in effect, the breast surgeon takes over and becomes the team leader for your coordinated care. The breast surgeon will present the new patient case to all of the subspecialists in the group, which include radiologists like myself, the pathologists, radiation oncologists, medical oncologists, plastic surgeons. Now, the patient may not need all of these support systems. The reason we present is because our job as a comprehensive breast program is one, to find the breast cancer, two, to make the patient disease-free. That's where usually the surgery comes in. And three, to keep the patient disease-free. And that part is so important and involves a coordinated multidisciplinary approach. That's why it's so important that you're in a program where the surgeons, the medical oncologists, the radiation oncologists, everyone is talking together and making the decisions together for the patient. And that's really unique, I think, in our breast center. That's one of the things we offer that's so important for patient care as opposed to a standalone facility.
Yes, yes. And off the script, if I may,
Yeah.
we know that having a support system, having this community also positively influences someone's health system navigation process, right? There's so many moving parts. And you spoke about a collaborative team, which is essential to have the coordinators, administrators, and your physicians a part of your care. So I appreciate the work that you guys do so much.
Well, you're absolutely right. It actually, the studies have shown that patients being treated in
Mhm.
a multidisciplinary care approach actually do have better outcomes.
Yes, yes, which is what we're aiming for. So high five to you.
Thank
So let's talk a little bit about breast cancer screening. Let's say that I'm interested in being screened. Which type of physician do I go to? How do I even talk to my doctor about breast cancer screening?
Well, I think as women, we always need to be advocates for ourselves and our own health. I think sometimes we forget that because we put everyone in the family first, and then you remember that you haven't done anything for yourself, right? It's important even if your primary care person, clinician does not bring it up, it is very important to bring it up to your doctor and say, I am due for my mammogram. I tell patients when you have your mammogram, whatever time point of the year you have it, you have it in if you have it around May, just remember when you start seeing the holiday cards for Mother's Day, it's time for you. Just have something that associates for you. If you have it now, when you see Halloween signs come up, it's time for you. It's time for you to go get yourself checked. It's important to have the conversation initially with your referring clinician. If you're at an average lifetime risk, you generally don't need anybody other than your referring clinician to do a clinical breast exam on you, and then either give you a script for a screening or diagnostic, depending on what they feel is necessary. I will jump to talking about what the patient needs to look for, because that also should be, patients should be aware and bring up any of these to the referring clinician. We really do think it's important for patients to know their own breasts and know their own, so that they can identify a change. So that means being able to identify if there's a new lump or a new thickening, skin changes like rashes or dimpling in the skin, nipple changes. For example, if you notice the nipple is retracting, pulling in, and nipple discharge. Nipple discharge can also be, most oftentimes it's not worrisome, but it can be a sign of something concerning. So any of these symptoms, if you notice it, or if a change in your breast size, particularly if one side is changing, these are things to bring up these conversations with your doctor. If you notice any of these, actually don't wait for your annual checkup time, but you should call your doctor and request to be seen earlier.
Those are helpful tips. And knowing many of our community members, we've had a series recently where
Mhm.
we've discussed which type of doctor you're going to bring certain things up. So, as far as any changes in our breast, would I speak to my primary care physician? Am I talking to my OBGYN? Who should I bring it up to?
You can speak to either of those. You should start with your primary care or your GYN, whoever you can get into first, because we don't want to sit on changes in any of these settings. Granted, many times the lump is not anything worrisome. It can be a benign cyst, which is a fluid-filled collection and nothing to worry about. But we don't want anyone to wait. We don't want anyone to stay anxious about what they're feeling. So the best thing is to reach out to your primary care or your GYN. Once you have the imaging done, if there is an unresolved finding or if there is anything of concern, then the imaging team will take on the role as to refer you to the next specialist, which would usually be a breast surgeon.
Great, that's good to know. And I'm going to jump ahead a little bit. So,
Okay.
if we could talk about, as we are talking about any signs or symptoms of breast cancer, can we talk more about dense breast tissue, different changes, things like that? If there are any screening tests, I think that that will be important to go to next.
Yes, I will tell you, I get asked about dense breasts and what they are and what they mean many times a day. And it's a good question, because we should know what our breast density is. And in fact, it's now a law that we've been following for a very long time in the DMV, but that all radiology reports now will actually begin with a statement for the patient about your breast tissue density. So when we talk about density, we're not talking about what the breast feels like on exam, but we're talking about what it looks like on a mammogram. On mammograms, what we see are different shades of white and gray. The white is really the glandular tissue. When you have more glandular tissue and less fat in the breast, the glandular tissue stops the X-ray beams. And I'd like to show, I'm a radiologist, I like images. So if you don't mind, oops, hold on a second. I would, oh, okay. Oh, perfect. You're on it. Thank you. All right. Can you hear me? Okay. I, for some reason, can't hear you.
Oh, can you hear me?
Oh, yeah, I can hear you.
Okay, I pulled your
Okay.
slide
So
up.
this is the image. Okay. So you can see the image on the left is got more white on it, and the image on the right is actually just more gray. So the more gray is because it's fatty tissue, and the X-ray beams have a really nice time penetrating and showing us what is inside this breast. On the white side, on the left side, you can see there's a lot of white, and unfortunately, many times cancers are also white. So white on white, as you can imagine, is actually hard to see. So we get white on white, and it's hard to see, and that's why breast tissue density makes it challenging for us to see cancers. And unfortunately, the other thing is that dense breast tissue has been shown to be moderate association with a higher incidence of breast cancer. So now we know there's more chance of breast cancer in the dense breast tissue and it's harder to see it. So that obviously makes it more challenging for us as radiologists. Can you show the next slide for me, please? So that's why we have this 3D tomosynthesis, which allows us to walk through the tissue 1 millimeter slice at a time. So instead of seeing that flat picture that I just showed you, we can walk through the breast to see if there's anything hiding, particularly in that white part. And can you show me the next slide, please? So in this case, these are two mammogram pictures of the same patient from 2011 and 2012. And this is what we were talking about before. We love to compare images because we like to make sure nothing's changing. And in this case, we did not see anything changing and it looked these are the 2D images, the 2D images, the flat images looked very similar. And then can you go to the next slide, please? And then so this is the same patient and the left side is the 2D. The right side is the 3D images. And you can see there's a spiculated little mass in the center of the breast. I don't think you can see my pointer, but yeah, just right there. Yeah, a little bit further down. Okay, go more up. This thing, that's it. There you go. That's that exactly. So that caught our eye. So we called this patient back and we did an ultrasound and found a tiny little 6 millimeter breast cancer. So this is something that, you can't see it on the flat picture because you can see the left breast, there's the flat picture. And gosh, if any of the audience can see that on that, well, you should give us a call because you probably can get a job at Hopkins. But none of us could see it. But when you walk through the breast tissue 1 millimeter slice at a time, it smacks you in the face. So that's why the 3D mammogram is so helpful in all breasts, but particularly in the dense breast. So it's been very helpful for us. We do use it. Most of our patients have 3D mammograms for that reason.
Great. Thank you so much for walking us through those images. I
Sure.
appreciate that. So
I
let's,
love images because I think it just shows it, right?
yes, yes. So how often do you feel like you're walking patients through these types of images? I think they're just very educational, even if you're not finding cancer, right? To see these.
Yeah. Well, when we have a new diagnosis or when we think something is suspicious, sometimes that is the best way to start that conversation with the patient is to review the imaging with them. You'll be surprised how the average patient can actually, like you correctly identified that area with your pointer. I mean, so I think everyone, has an eye for what doesn't look normal. And I think people see that. So I think it's very helpful for patients who we want to have that conversation to start by looking at the images together, particularly when it's something really worrisome. So we do that when it's necessary.
That's very important to know. And why do you think patients may be hesitant about going through these screening procedures, or what do you even say to patients who are hesitant about screening and treatment?
Well, I mean, I have to say it's been documented. Screening saves lives, and as we talked about before, I think there's just patients are anxious about the false positive, about the recalls. I think patients just need to remember that most of the recalls are not anything worrisome, and we can remedy everything with just 1 or 2 pictures and give you peace of mind that there's nothing to worry about. And then we really need to remember that this is something that we need to do for ourselves as women, and we need to make sure that every woman in our life does this because it doesn't take more than 20 minutes, and it really does. Mammograms save your life. There's no question about it.
Yes, I love that. I feel like that's a great elevator pitch. Just 10
it,
seconds, it saves your
it
life.
saves your life.
Let's do it.
Yeah, the studies have shown it. I mean, it's one of the screening tests that has been documented to reduce mortality since we've been using it. So I just it breaks my heart when I hear people not going for their mammogram. And it's interesting the reasons people get for it. People will say, I don't have a family history. Well, 75% don't have a family. 75% of women with new diagnosis don't have a family history. And that's just, that's, I think we need to hammer that home, that while it's good you don't have family history, but just because you don't doesn't mean you're not going to get breast cancer.
Yes, I love that point. I think that we're often speaking about family history, so it's always great to tackle that type of misinformation. So, if you had one thing that you could tell people about breast cancer screening, we know you're saying go get it, it saves lives,
Yeah.
but anything else, what would it be about the screenings?
Um, I mean, I can't say anything other than you got to get it. It saves your life. You have to be your own advocate. You have to get your friends to go. If you care about a woman in your life, whether it's your mother, your sister, your neighbor, whoever it is, you really need to just make sure they go. I mean, you know, I'm anybody who knows me, I wear shades of black, gray, and brown all the time. And this is the only time in my life where I'm like, put it, the pink. You got to do it. It's a little thing to do for yourself, but you absolutely have to do it. And you have to know your risk factor. You really do. You have to know where you lie with and which your risk factor is compared to the general population. Because if you are at a higher risk, then a mammogram may not just be enough for you. You may need to add an MRI to it. And we have everything available for our patients. We just need you to come so that you can get screened.
Yes, yes, come bring your sisters, your mother, everyone.
Oh, you'd be surprised, Kimberly. There's so many people who come together. And
Oh,
it's lovely. You'll see friends who come together every year. You'll see moms and daughters who come together every year, sisters who come together every year. It is actually lovely to see that. They have it as their routine. They come and do it and then they go out for coffee. They come and do it and they go grab a bite to eat. It's a lovely thing to do for yourself and the person you love.
yes, I appreciate that so much. I'm all for girl power. So
Yeah. Yeah.
So, as we close our interview questions and open it up for questions, so if you guys have questions, please put them in the chat. But the final question I have for you, and we have some in the Q&A.
Yeah.
So, what new things are happening in the field? What developments are you excited for? We want to have some hope, Dr.
Yes,
Bobby.
I
We
am
need
very excited. I have to tell you, I'm very excited about AI, AI and mammography. So, AI is, as you know, computer algorithms that have taken the data sets and have been taught to basically try to mimic human intelligence or processes that generally humans do. So when it comes to mammography, there are about 20 or so FDA approved software systems that have been approved to actually read mammograms. And so when you look at the data, a lot of my colleagues were initially scared all over the country because they thought, oh my God, we're all going to be out of a job. But when you look at the data, AI is actually really good when it's used as a second reader with the radiologist. So the data shows that AI, when it's used as a second reader, can actually cut down on the false positives, the recalls that we were talking about for the screenings, and can actually increase finding little cancers that we may not be able to see otherwise. So at Johns Hopkins, we actually formed a subcommittee and looked at the three top AI software systems, and we sent in our own cases. We looked at their cases, and we landed on one in particular that we have been using since March. I'm very proud to say, first of all, that we are not charging the patient for AI as some other facilities are. We feel strongly that if we have a technology that can benefit our patients, we want to allow access. Again, we're talking about access. We want to allow access to that technology for everyone. We don't want it to be an add-on feature. So every mammogram that's done within the Hopkins system since March has had a double read with AI. The way we do it is that the radiologist reads it first and AI reads it after us. And then hopefully the radiologist and AI agree. If the radiologist and AI do not agree, then we actually have a system in place where we'll ask a colleague, another radiologist to kind of be a tiebreaker or, give their insight as to what they think. And that's how we've been doing it. I'm very pleased with what we're seeing with AI. And if you want to show slide 8, I'd be happy to, I love pictures, so I'd be happy to show one of our most recent cases. Um, thank you. So this is a mammogram that is on the far left corner. There's a regular 2D imaging of the mammogram. And then the AI, when we were scrolling through the 3D images, you can see where the blue arrows are. The AI picked up a little area where the tissue is pooling on itself. It's what we call distortion. That concerns us when we see that because we think there might be something in the breast that's developing that's not respecting the tissue around it. So that concerns us. So we zoomed in on that area. That's the top picture that you're seeing on the screen, the top in the middle, the spot view, labeled spot view. And you can see when you zoom in on it, you can actually see that the tissue is pooling. That's the architectural distortion. And then we took this patient to an ultrasound and we see on the ultrasound that little black area exactly that kind of looks like a seahorse. Yeah, that's actually kind of does look the same as the area on the spot view. That was actually the area we saw, and it is a little irregular mass. So we did put a needle in it. We did an ultrasound guided needle biopsy. That's a same day biopsy. We just, the patient, it's a 20-minute procedure. The patient can come by themselves. They eat before they come. They don't need somebody to drive them. And after we did the biopsy, we put a little marker clip in there and we repeated the mammogram. That's the rightmost mammogram called post biopsy. And that little white dot is the marker. And if you compare the left images to the right images, the little marker is directly where the AI picked it up. And that did come back as an invasive lobular carcinoma, which traditionally is one of the hardest kind of breast cancers to pick up just because of the nature of how they grow. And so in this case, the AI did a really nice job of helping us find a very tiny, subtle cancer. So I do think AI is very promising. It is not at a point where it's going to read mammograms on its own yet, but it has actually been very useful just like the data showed, it has been useful for us in terms of finding little tiny cancers that are subtle, and as well as decreasing our recall rate. I mean, so we actually do have mammograms that we're calling back potentially less often. The data, we've only been doing it since March, so we're going to give it a full year before we can really see the trend of it. But anecdotally, it does feel like we're calling back less. So, I mean, and there's a learning curve with that, but I'm very excited with it. So far, it's been very helpful for us.
Wow, that was amazing to see. And I appreciate you all using that technology. As we're thinking about, as I'm thinking about
Yeah.
health literacy, how are we explaining to patients this double process of radiologist viewing and then AI viewing? Are we explaining it to them? How are
Yeah.
we getting them in
So
there?
for patients that I personally, when I walk in the room and there's a diagnostic patient that I'm reading, I do tell them that, good news, I read your mammogram first, AI read it after me, and we agreed. We didn't see anything worrisome. And patients love it. Actually, it's so interesting because they're not concerned, they're not worried, oh, there's too much computer technology here. Patients love the fact that there's computer technology helping us assess and making sure that we're looking for early breast cancers. So the feedback from patients has been great. And the fact that we're not charging for it is obviously even better. So yeah, I'm pleasantly, I guess I'm not pleasantly surprised. I was hoping, and I'm seeing what I was hoping for, that patients are actually really thrilled to know that we are using the newest technology and everything that we're doing at the Hopkins systems.
Yay, that's very exciting. That makes me excited as well, Dr. Razavi. So we do have a few questions that I
Yeah.
want to jump to in the Q&A. So our
Okay.
first
I see
question,
someone's asking about the patient navigators.
yes.
Sure. So that's actually really important. It is something that I think is very special in our departments. We do have patient navigators and coordinators in place in many parts of our diagnosis. So one from when it comes to, helping you schedule for the biopsy if you should need a biopsy, and two, to helping the patient schedule with the breast surgeons if they need to be seen by a breast surgeon. We have navigators and coordinators in place for all of those parts of the diagnoses, and they're important, really key components of our program because um, in both figuratively and virtually, they can be your handholder. Because if once you get off the phone with the doctor or you come out of the doctor's office, there's always things that you think, oh, I should have asked, or I could have asked, why didn't I ask? Or what is this thing that just came up? And these the navigators are usually very accessible to the patient. And if it's something that the navigator can't do, then they have very easy access to the physician. So the physician, whether it's the radiologist or the surgeon, it will be the next in line. And so the process is put in place to make sure that patients have some form of direct follow-up and kind of virtual hand-holding or physical hand-holding going through this process that, you know, unfortunately, and as no one should be ready for breast cancer, but we have these wonderful patient navigators and coordinators in place. And we really take our time vetting who we want to have these positions because we know it's not just about having the intelligence to do this job, but you have to be the right person for it. And I think we really put effort into making sure these are people who can empathize and be people who can actually walk alongside the patient during the process.
Yes, I appreciate you answering that because the process could potentially take some time, right? So you want
Yeah,
to make sure people feel comfortable.
yeah.
Mhm.
I also
Okay.
I also see someone's asking about risk assessment and Tyrer-Cuzick's risk scores. So, these can be done. Sometimes they're done by your referring clinician. A lot of times, gynecologists will actually do this in their offices. Some gynecologists do this. If you have any question about these, really, there are geneticists within the Hopkins system and the Hopkins sites, including the NCR with the Sibley and the main campus. And so don't hesitate to reach out because they can do a quick conversation with you and decide if you need to be screened based on your family history and your lifetime risk will be better assessed that way.
That's great. And could you explain a little bit about what Tyre Cusick is?
Yeah, so that's just a risk assessment tool. So it goes through it's like a questionnaire, almost like an intake questionnaire. So the physician will ask all the questions, and at the end, it actually gives you a lifetime risk. So if the lifetime risk is over 20%, then we know automatically that we have to add the additional screenings, such as those MRIs. So we don't want patients with a lifetime risk of 20% to just get the mammogram. Of course, mammogram is still key. Everybody needs to get a mammogram, but we know that for those patients, we would add additional screening, which would include breast MR. And I
Wow.
see somebody is asking about BRCA mutations. The question I think is if you're if you have a first degree relative, let's see,
Yes, if you have a first degree relative with a BRCA mutation that you're high risk, is a family history of breast cancer for non-BRCA mutations still considered high risk?
it can be. So one of the things that is noteworthy is that sometimes we'll see breast cancer in multiple members of the same family. And you think there has to be a genetic association, and the BRCA is negative, and the other genetic panels are negative. So it may be that we just haven't discovered the genetic association yet for that family particularly. And then also the panels are continuously getting updated. So it may be that if the relative was tested a few years ago, it was before the latest update of the panels, and when the relative needs to be retested. So that is also the other thing, the other consideration, and why a geneticist would be someone who would be really appropriate to talk to about this, because then they can look and see when the genetic testing was, and the panels have been updated since then, should the patient have retesting done to get a better analysis.
That's wonderful. Thank you for answering that. I'll give us a few seconds. If anyone wants to use the raise hand icon, you should have an option to react. If you have a question that you would like to ask Dr. Razavi, and I'll make sure that we call on you. Any final questions? But thank you so much, Dr. Razavi. I learned so much in this hour, and I am a cheerleader for breast cancer awareness. So I'm going to make sure I wear my pink this month.
Thank you, Kimberly. Thank you. It was really fun chatting with you. I really appreciate you asking all the tough questions. I really appreciate your enthusiasm for helping us with getting the word out to everyone. And if anyone has any questions, just reach out. We're here to help.
Yes, yes. So if anyone has questions, we'll make sure that we send out the recap video. This was recorded. Please, please, please share with everyone you know, especially this month. But I don't see any questions. So thank you so much, Dr. Razavi, for being here. Do you have any final thoughts, anything that you would like to leave us with tonight?
Kimberly, you know what I'm going to say is get your mammogram.
Yes, yes.
Everybody get your mammogram. And if you have any questions about when, how, anything like that, please reach out. We have people at all of our breast centers in the Johns Hopkins sites. We have advocates, we have people who can go through information for you. So you should never have a question that you cannot find an answer to. If you have any questions, call us. We're happy to help.
Yes, yes. Thank you so much, Dr. Razavi. Thank you, everyone, for being here with us tonight. Have a wonderful night. Good night.
Thank you. Thank you. Bye bye.